Good morning, everyone, and welcome to today's webinar hosted by PYA. Today, we are continuing our Healthcare Regulatory Compliance webinar series with a presentation on 2023 Medicare Physician Fee Schedule Final Rule, Part 1. PYA is happy to present today's webinar on this important topic. You will have the opportunity to submit questions to today's presenter by typing a message into the question pane of the control panel. We will collect these and address them by email after the webinar. All of our webinars are recorded and released with a copy of the slides after the event. With that, I would like to introduce Martie Ross, Consulting Principal at PYA.
There we go. Good morning, everyone. Sorry, a little trouble getting the slides to move this morning. Thanks for joining us. Today is the first of our three-part webinar series on the 2023 Medicare Physician Fee Schedule Final Rule. The rule was published in the Federal Register on November 18. It weighed in at a mere 1,297 pages. That does not include the 27 additional schedules and documents that CMS posted to its website that relate to specific provisions in the final rule. So certainly there's a great deal of content to cover. Today, we're going to drill down on the 8 topics you see here on the screen. Next week, next Wednesday, my colleague Valerie Rock we'll do a deeper dive into the provisions of the rule concerning evaluation and management code changes. And then on January 11th, Lori Foley will lead you through the changes to the quality payment program, including MIPS and advanced APM. So through that, we will cover most of the content relevant directly in the rules. But before we talk about the Medicare Physician Fee Schedule, let's talk about some good news. Specifically relating to the No Surprises Act. If we were receiving calls from folks with questions and concerns and a little bit of panic, they were relating to the requirement in the No Surprises Act to provide a good faith estimate that included not only the convening provider's estimate of charges, but beginning January 1st of 2023, the expectation that those GFEs for self-pay patients would also include estimates for co-providers. CMS had delayed the enforcement of that specific provision of the No Surprises Act to January 1st of 2023. And so we were getting nervous that we would have compliance requirements beginning next month. But Friday afternoon, late Friday afternoon, CMS published an FAQ regarding the GFEs and announced that it was indefinitely delaying the enforcement of the co-provider, co-facility requirements for good faith estimates. So take a deep breath. Going forward, we will continue to have to provide GFEs to self-pay patients for our own charges as appropriate, our own estimate of charges, but we will have a delay, indefinite delay, in the requirement to provide that comprehensive GFE. You see here on the screen quotes from the FAQ that CMS published, highlighting that it is now tying the enforcement of those provisions to the development of a vehicle for sharing that information between providers so that they can provide that more comprehensive GFE. Stay tuned. We're most likely going to see a proposed rule that will give us the enhanced compliance requirements as well as a date going forward. But for now, that is off the emergency list. So back to the Medicare Physician Fee Schedule, and we'll start with discussion of the conversion factor. And begin with just sort of a base lesson in how fee schedule payments are calculated. And we start with, for each service reimbursed under the Medicare Physician Fee Schedule, CMS assigns a relative value to that service. And those are measured in relative value units, or RVUs. And for each service, there are 3 types of assigned RVUs: work, which is the physician's professional services; practice expense, the cost of delivering that service; And then malpractice expense, which is the risk associated with the service and the necessary compensation within the reimbursement for that risk, obviously through malpractice insurance coverage. A significant part of that 1,297 pages of the final rule regards the assignment of these RVUs for different types of services. In fact, next week, Valerie will cover the changes in RVUs related to certain evaluation and management codes. But through each year of rulemaking, CMS continually tries to improve and enhance the accuracy of RVUs to truly meet the inputs required to deliver the services and thus have appropriately aligned reimbursement. Once you have the appropriate RVUs assigned to a service, you determine the payment by multiplying that total number of RVUs across those three categories by the conversion factor. And the RVUs times conversion factors provides you with the national payment rate for that particular service. The calculation of the conversion factor is determined by statutory provision. And the amount of the conversion factor is dependent on the statutory dollar amount that is to be devoted to Medicare physician fee schedule payments. So we know how big the pie is. It's then a matter of dividing the pieces of the pie, and the conversion factor effectively provides the knife by which we make those cuts. So prior to 2015, the conversion factor was determined on some horrific formula that involved the Medicare inflation index and the sustainable growth rate. And it was a mess on an annual basis because there was such a disconnect between the sustainable growth rate and the historic conversion factor that each year we would be facing significant cuts in the total amount being spent on the Medicare physician fee schedule. And each year Congress would have to step in with the fix to the fee schedule issue. So in 2015, in the Medicare Access and CHIP Reauthorization Act, or MACRA, Congress created a new formula for CMS to apply to calculate the conversion factor. And it is, those formula varied by time period. So right now, in the time period 2020 through 2025, we are in a period in which Congress mandated a 0% increase in the conversion factor. So in prior years, we had increases in the conversion factor, but during this period of time, there is to be a 0% adjustment to the fee schedule. However, that's simply the upward adjustment. There is still the impact of the budget neutrality requirements on the conversion factor. So to the extent that CMS in its rulemaking makes upwards or downward adjustments to RVUs or increases coverage, so it provides new coverage for new services, if the financial impact of those changes, so if we previously had an RVU that was, if you had a service whose total RVUs were 1, and we adjust the RVUs and say now the RVUs are going to be 1.2, we know that that service is going to be a larger component of the fee schedule. So we have to make other adjustments to account for that increase in the total RVUs because the total Medicare Part B expenditures have to remain effectively the same. So at the end of the rulemaking process, if the changes result in more than $20 million swing in the total cost of the program, the budget neutrality provisions then require a corresponding reduction in the conversion factor. The last component of the conversion factor, or how we calculate fee schedule payments, is the geographic adjustment factor. And this is, we talk about the national payment rate, which is effectively the base. We then adjust the conversion factor based on geographic factors. So if we look at certain costs of providing care in one region and compare that to another region, we weight those regions based on their relative costs. So if one is this is the average. Some regions are going to be higher, some regions are going to be lower, and that is the adjustments made to the conversion factor to give you the specific geographic payments as opposed to the national payment rate. So those are all the inputs that we consider in setting the conversion factor and the fee schedule payments. Let's look at what's happened to the fee schedule historically so you can appreciate what's going on now in the final rule here in 2023. So start in 2019 when our conversion factor was $36.04. And then we enter that period of zero adjustments under MACRA. That meant in 2020, our fee schedule rate was $36.09. There was a slight, very slight adjustment because the actual number of RVUs projected went down. In 2021, and this was sort of where the bell started ringing that we had a problem, the proposed conversion factor was $32.26, a significant reduction right in the middle of the pandemic. And that was driven primarily by significant changes that CMS had made to the RVUs assigned to evaluation and management services. CMS had a plan to increase payments to primary care providers, and they were executing on that plan by increasing the RVUs assigned to the traditional evaluation and management services. They also had proposed an add-on code to reflect the complexity of care in evaluation and management services. And when CMS did the math, they determined that those adjustments would increase the total number of RVUs being submitted by providers, and thus that forced that significant reduction in the conversion factor. Obviously, the industry was very concerned seeing that reduction in the conversion factor. Congress stepped in the Consolidated Appropriations Act of 2021 and did a one-year increase in the conversion factor, bringing that payment rate up to $34.89. So we get to 2022, and the proposed conversion factor, again, adjusting for those changes in evaluation and management codes, CMS proposes the rate at $33.59. And again, Congress steps in, this time in the Protecting Medicare and American Farmers from Sequestration Cuts Act. That rolls right off the tongue, doesn't it? They provided for a one-time 3% increase in the conversion factor, meaning that in effect, the conversion factor now in 2022 has been $34.61. That gets us to July this year when CMS rolled out the proposed rule and announced that the conversion factor would be $33.08. That was attributable to the sunset of the 3% increase, that 3% increase that had been provided for by statute at the end of 2021. But also these additional RVU adjustments that CMS has proposed for evaluation and management codes here to become effective in 2023, as well as other updates that CMS was making to the geographic rates and malpractice RVUs. And all of that together, again, because we added the additional RVUs, we had to cut down the conversion factor to the proposed $33.08. Again, as you'd expect, a flurry of concern from the industry about reducing physician payments. At this point, in the final rule, CMS announced the conversion factor at $33.06, and that will be what takes effect January 1st, absent any legislative action. And we'll see here in the next slide exactly how we got from the $33.08 that had been proposed down to $33.06, which is the final. So we start with the 2022 conversion factor. We back out that 3% increase from the legislative initiative at the end of last year. We know the statutory update is 0 for this year. And then we have the budget neutrality adjustment. And CMS set that budget neutrality adjustment at 1.55%. So the only thing CMS could do to change the conversion factor would be to reverse its increases that it's proposed to different assigned RVUs to different services. They otherwise can't wave the magic wand and increase the conversion factor. And so that leaves them with the proposed $33.08. What happened in the final rule is that budget neutrality adjustment went from 1.55 to 1.6, and that's what gets us to the conversion factor of $33.06. Again, the only thing that's going to change that at this point is legislative action. Similar to what we used to go through with the sustainable growth rate, the SGR, for every year, we will have to wait to see if Congress steps in to intervene to change the conversion factor. Unfortunately, that's not the end of the bad news. In fact, that's pretty minor bad news compared to the other cut that we are now facing. And this gets us into PAYGO and sequestration cuts. So back in 2010, when Congress couldn't get along to determine how they were going to finance the government without shutting it down, the solution became the Statutory Pay-As-You-Go Act of 2010. And it requires, it's effectively the disciplinary tool that Congress imposed on itself, saying that we have to have mandatory spending, we have to have mandatory cuts to non-discretionary spending if Congress increases spending or decreases revenue without an appropriate offset. So that's effectively a big old budget neutrality requirement across all congressional action that impacts the federal budget. When Congress implements spending, additional spending, without providing any sort of offset or exception to the PAYGO requirements, it then falls on the Office of Management and the Budget within the executive branch to implement sequestration that impacts all types of mandatory federal spending. And that includes all Medicare provider payments. You know that for a whole long time now, we've had a 2% sequestration in effect. And because we've extended it and repackaged it, that sequestration will remain in effect through fiscal year 2031. And that 2%, in fact, dates back to that 2010-2011 time period that was the sequestration necessary to pay for effectively funding the government during that period of time. Fast forward to 2021 with the passage of the American Rescue Plan, which was sort of the last of the COVID relief bills. All of its predecessor COVID relief bills had included provisions that exempted the additional spending from PAYGO. Because of the recognition of a national emergency, Congress agreed to increase the size of the federal budget deficit by those expenditures provided in those COVID relief bills. And so that did not impact sequestration. But when you get to this last piece of legislation with the American Rescue Plan, there's no offset or exemptions included in that legislation, and thus it triggers sequestration and including cuts to Medicare. Those sequestration cuts that should have gone into effect in 2022, that same piece of legislation that provided that 1 year 3% increase in the conversion factor also deferred those sequestration cuts through the end of this year. And so here we stand now, absent any legislation, that there will be a 4% cut to all Medicare payments, not just Medicare physician fee schedule payments, but all Medicare payments that's set to go into effect January 1st, 2023. And despite that fact that it is less than a month away, it is presently not clear how that interacts with the existing 2% sequestration. In fact, I cite here a report from the Congressional Research Service in March of 2022 saying just that. Congress has never specifically addressed whether we're supposed to stack these sequestration cuts. So we have a 2% cut that's historical. We have a new piece of legislation that generates a 4% cut to pay for the cost of that legislation. Does that mean we then on January 1st have a 6% cut, or do we only total it out at 4%? So it's a wait and see. We'll need to see some guidance coming out of CMS on which it was going to be. But that does present us with a worst case scenario that the conversion factor could go from 33.91, and that's actually the prior conversion factor with the 2% sequestration applied. So once you apply the cuts because of budget neutrality, the 2% sequestration, and you apply this new 4% sequestration, we could in fact be looking at an 8.36% reduction in Medicare physician fee schedule payments. So it is not just the bad news of the conversion factor being lower. It is this issue unresolved at this point of the sequestration generated through the American Rescue Plan dollars. So that is one significant issue we're looking to Congress to see if there's going to be resolution prior to the end of the year or resolution early in the next legislative session that will address this sequestration. Because again, it's not just the physician fee schedule, it is all Medicare payments will be subject to this at least 4%, potentially 6% sequestration reduction. So that's the bad news. With that, let's shift gears and talk about something different. Let's talk about what CMS has done with telehealth services in this in the final rule. And we really have to start with, when we talk about telehealth services and the changes CMS has made, I think we always have to go back to the beginning and talk about the coverage limitations on telehealth services in the Social Security Act. When Congress introduced coverage in the early 2000s for telehealth services, in Section 1834M of the Social Security Act, it imposed 5 restrictions on coverage: the geographic restriction, location restriction. That means it has to be someone in a rural area physically present at a facility for the services to be covered. We had the service limitation that only certain types of services would be reimbursed if delivered via telehealth. We have the provider limitations. Only certain types of providers could provide services via telehealth and receive reimbursement. Those did not include therapists, did not include rural health clinics or federally qualified health centers. And finally, we had the technology requirements that you have to use a telecommunications technology that provides for both real-time audio and visual connectivity with the patients. So not surprising, pre-pandemic, telehealth comprised a minuscule portion of total spending under the Medicare physician fee schedule. With the COVID-19 public health emergency, before the COVID-19 public health emergency, Congress had begun making some exceptions to those rules and expanding telehealth coverage in very specific areas. First with telestroke, then with provision of services for end-stage renal disease, and then finally substance use disorder. In those 3 categories of services, Congress waived the geographic and location restrictions, meaning that these services could be provided via telehealth to a person in their home, regardless of whether they resided in a rural or urban area. Congress also made provision that allowed Medicare Advantage plans beginning in 2020 to provide broader coverage for telehealth services. The Medicare Shared Savings Program had provisions within its regulations that afforded those ACOs that assumed downside risk to provide telehealth and receive coverage on a much broader basis. And finally, there were multiple Center for Medicare and Medicaid Innovation initiatives that also provided for additional coverage for telehealth. So that's where we stand March 2020. Obviously, the world changed in March 2020, and we had the expansion of telehealth coverage. That started with one of the first COVID relief bills that waived the geographic and location requirements for the duration of the PHE, and then authorized the Secretary to waive other 1834M requirements as appropriate. CMS through 2020 issued a series of interim final rules that both expanded the types of services that were eligible for reimbursement significantly. We went from a list of 100 codes for which reimbursement was available for telehealth services to about 250 through the course of these interim final rules. It also made exceptions that permitted the use of telehealth for providing different levels of supervision rather than having direct supervision that requires physical presence. CMS permitted that supervision to be accomplished via real-time audio-visual connection. CMS also expanded the types of providers who could be reimbursed for telehealth services, including the therapists and speech and language pathologists, and also provided coverage for services furnished in rural health clinics and federally qualified health centers, as well as certain telehealth services for outpatient hospital services. CMS also created the ability to receive reimbursement for certain audio-only evaluation and management codes for the duration of the PHE. And CMS also, to encourage the adoption of telehealth, provided additional reimbursement. Before the pandemic, all telehealth services were reimbursed at the lower facility rate, regardless of whether the service was delivered in a facility or a physician practice. CMS changed those rules and said for the duration of the PHE, we're going to pay at the higher non-facility rate to encourage the utilization of these services. Other agencies get into the mix as well. They say, the OIG says, we'll permit waivers of co-payments for telehealth services. And the Office of Civil Rights says, we're not going to worry about HIPAA security compliance for utilization of certain technologies to deliver telehealth services. And the Drug Enforcement Administration, under separate statutory authority, says we'll allow telehealth to be the visit, the required patient visit, as to provide a basis for prescribing controlled substances. So this is where we live today under the continuing public health emergency with this incredible expansion of telehealth services. But CMS was very busy in the 2023 final rule in terms of setting the stage of what telehealth will look like going forward. First thing CMS was challenged with was implementing the provisions of the Consolidated Appropriations Act 2021, which eliminated the geographic and location restrictions related to services for mental health disorders. That's the terminology from the statute, mental health disorders. And CMS, through both the 2022 rule and now the 23 rule, have implemented the requirements with regard to in-person visits that to deliver these services via telehealth for patients going forward, there must first be an in-person encounter within 6 months of the initiation of the telehealth services. And then every 12 months, there must be another face-to-face visit. In this rule, CMS has clarified that 6-month requirement to have an in-person visit will not apply if, in fact, telehealth services were initiated with that patient during the public health emergency or for a period of 151 days following the end of the PHE. So that's the only exception going forward to the 6-month requirement for the provision of telehealth services without regard to geography or location for individuals receiving services for a mental health disorder. With regard to the 12-month follow-up, you have to have an in-person visit every 12 months. CMS has finalized rules now that provide exceptions based on beneficiaries' circumstances. The provider determines it's not appropriate for the individual or it is not feasible for the individual to be seen face-to-face every 12 months. They can provide an exemption to that requirement, provided that information is documented in the patient's record. Finally, CMS has, through its rulemaking, determined that for the provision of these services, a provider may use audio-only communication. Again, remember, the statute that authorized telehealth coverage for mental health disorders only varied the geographic and location requirements of 1834N. It did not change the technology requirements. But CMS, again, through its rulemaking, has come in and said these services can be delivered audio only, provided that the practitioner, in fact, can deliver audio or visual services. It is, in fact, the beneficiary either lacks the capacity, they can't connect visually, or they simply refuse to do the visual connection. And again, that will need to be documented in the medical record, and the provider will include a service level modifier on the claim to indicate that case. So that's where the rules stand today regarding the future provision of telebehavioral health services. Again, this kicks in post-PHE. It is not the rules in effect today, but we have everything set up, ready to go following the end of the PHE. In fact, not just the end of the PHE, because there's an extension in place for the telehealth rules. So Congress, in March of this year, steps in and says, well, we already expanded telehealth coverage for behavioral health services, but we really want to have sort of a glide path off of the broad rules that applied during the PHE. So we have decided, Congress decided, that they will extend for 151 days following the end of the PHE, the existing telehealth policies for those services that were on the telehealth services list as of March 15, 2022. And you see here the specific provisions that were made in that legislation. Again, in the 2023 final rule, CMS has developed the regulations to implement these telehealth extensions. That includes addressing the Medicare telehealth services list. CMS has determined that it will extend coverage for all services that have been included on a temporary basis for a period of 151 days. And that includes those services that CMS has added to the telehealth list since March 15, 2022, that had been at issue because the legislation actually said only for those services on the list as of March 15th. CMS comes in by regulation and said, well, we'll extend it even more for these services that we've added to the list. And they've continued to add to the list, including after March of 2022. You can find that list at that website noted here. CMS then said, we're creating this category, this new category of telehealth services, which they cleverly refer to as Category 3, since we already have a Category 1 and Category 2. These Category 3 services are going to be those for which we will continue to provide coverage through the end of 2023. And the list of those services appears on Table 12 in the final rule. You see a really bad copy of Table 12 there on the side of the slide. But effectively, it is all the services except the telephonic evaluation and management codes and the initial care codes. So when you're initiating services with a patient, those no longer will be covered telehealth services after the end of 151 days at PHE. For those services then that are on this expanded list and will continue to be covered through the end of this year, keep in mind that on day 152, the geographic and location restrictions go back into effect. So even though you can provide the service via telehealth because it's a covered service, you will not be able to provide that service unless the individual is residing in a rural area and is physically present at a facility at the time the service is being delivered. So yeah, there's some given there. You can continue to provide these, but again, that layer of the geographic and location restrictions go back into effect on day 152. Also in the 2023 rule, CMS included some additional Category 1 codes. These are permanent additions to the list. Those are primarily related to the change in evaluation and management codes and the addition of new chronic pain management codes, which we'll talk about in just a minute. So that's where we stand on telehealth services. We are, again, watching Congress to see if they're going to make any additional changes. There was legislation that passed the House of Representatives on a nearly unanimous vote this summer that would have extended these telehealth exceptions through the end of 2024. The Senate never picked that legislation up up to now. We do have a lame duck session. We will see if that expansion of telehealth services gets rolled into something else. Certainly appreciating there are a lot bigger fiscal notes that Congress is dealing right now, such as sequestration. So we'll see if anything happens going forward. Otherwise, I think we can hunker down and prepare and appreciate that the world will change significantly day 152 following the end of the PHE. Part of what we're going to change are how claims are submitted and what payment will be for these services. Through day 151, CMS will continue to pay for telehealth services at that higher non-facility rate, and you'll continue to append modifier 95 to those telehealth services. And you will continue to report the place of service for telehealth services as if the provider had furnished the service face-to-face, so where the services were normally performed by that provider. After day 152, again, we're reverting to the old rules. We'll discontinue the use of modifier 95. Instead, we will use place of service 2, which is telehealth services provided other than at the patient's home, and the new place of service 10, which are for telehealth services provided in the patient's home. And again, that's limited. That's limited to those new rules on behavioral health, as well as those pre-existing rules for telehealth services related to end-stage renal disease and substance use disorder. Remember, those were enacted before the pandemic, and we will be able to continue to provide those services without regard to geographic or location restrictions. The other bad news here is the payment for telehealth services will revert down to that lower facility rate. CMS says that they think that still is the appropriate payment level because a practice incurs less expense when it delivers services via telehealth. Obviously, an opportunity for comment next year. If you are providing audio-only services, you will include modifier 93. Remember, as we were talking about the delivery of telehealth services for behavioral health conditions, CMS noted that they would permit those services to be delivered audio only if there was a determination that was not an appropriate, the audio visual was not appropriate for the patient. The modifier you'll use to indicate that that is the case will be this modifier 93. And then we will continue to use the FR modifier to indicate that they are incident to telehealth services are being billed by the practitioner furnishing direct supervision versus real-time audio visual. So again, if you're delivering telehealth incident to a physician services and the direct supervision is being furnished by the billing practitioner via telehealth, then that's when you use the modifier FR. That's been in place since the beginning of the PHE, but soon thereafter. Finally, CMS concludes in the final rule saying, yeah, we'll issue some regulatory guidance as needed to implement all of this going forward. So we have what's in the final rule now. We have a pretty good idea of what the world looks like post-PHE for telehealth, but CMS says we know there's obviously some gaps we're going to need to fill, challenges that will arise. We'll address that in sub-regulatory guidance, so we do not necessarily have to wait until the next year's final rule to address those issues. Finally, I promise, last thing on telehealth is the issue of direct supervision. As you know, direct supervision is required for incident to billing. It is required for certain diagnostic tests that are billed under the busy schedule. It is required for the delivery of pulmonary rehab services, as well as cardiac rehab and intensive cardiac rehab. And we know that direct supervision means that the practitioner must be physically present and immediately available to provide assistance. So physical presence is required in the same suite of offices for these services to be billed under a practitioner's number, although the services are being delivered by other staff. During the public health emergency, CMS has allowed a variation in the definition of direct supervision, stating that physical presence can be replaced by virtual presence using real audio or video technology. Now, that doesn't mean if you're the clinical staff providing the services incident to, that doesn't mean that the phone has to be on with FaceTime with the provider right there. It just means that you are able to reach the provider at the time you're delivering the services, that they are available to provide that direct supervision via audio visual connectivity. CMS has decided that it will continue that rule through the end of the year in which the PHE ends. And we're all predicting that at some point in 2023, the PHE will not be renewed. So through December 31st of next year, this type of direct supervision will continue. But starting January 1st, 2024, we will revert back to the physical presence requirement for these services that require direct supervision. However, CMS hedged its bets, and you see the language here from the final rule saying that maybe in the next year we'll get comfortable with this idea of virtual direct supervision, at least for certain services. So hopefully when we see the proposed rule for 2024 next July, we'll see CMS either making a blanket decision to permit virtual direct supervision, or will permit it for certain types of services. So that's definitely one to watch going forward. Certainly, we are very well aware that this expansion of direct supervision has provided numerous new ways to provide services effectively and efficiently to beneficiaries. We'll see how much that will stay into place going forward. Oops, sorry, the screen goes to sleep sometimes on me. Let's switch gears from telehealth services and talk about changes in the final rule regarding behavioral health services. We've already addressed all the rules CMS has now developed around telehealth provision of behavioral health services. Let's talk about, these are different types of expansions that they are providing here. And one more time, let's talk about incident to services. And this is actually a change in the actual regulatory language that CMS has made. So CMS, first of all, clarifies that any service that can be furnished for the diagnosis or treatment of a mental health condition or a substance abuse disorder, those services can be furnished by auxiliary personnel, such as licensed professional counselors or licensed marriage and family counselors, incident to a physician's services, provided that that physician or non-physician practitioner can in fact bill for that particular service. So just this is CMS simply acknowledging this has always been the case, that these appropriate auxiliary personnel can furnish these services, not bill them under their MPI, but instead those services are billed under the physician or non-physician practitioner's MPI, provided the incident to rules have been satisfied. CMS says we've got a big brand strategy to improve access to behavioral health services. As part of that strategy, we are going to change the definition of direct supervision in the regulation. And instead, we're going to permit incident to billing for these types of services furnished by auxiliary personnel under general supervision. So no longer requiring direct supervision, now general supervision. And not even virtual supervision. This is truly general supervision. So you recall, general supervision, no physical presence requirement, no virtual presence requirement. Instead, it is not a service by service level of supervision. It is instead the billing practitioner assuring that the individual is appropriately qualified, has appropriate experience to deliver that specific service, which has been delegated by the billing practitioner. So that will be permitted now for behavioral health services furnished by auxiliary personnel. What we have to be attentive to here is what is auxiliary personnel. CMS still continues to refuse to define who qualifies as auxiliary personnel, other than to say the individual has to meet any state licensure requirements for furnishing that service. So if a practitioner, a physician or a non-physician practitioner has delegated certain behavioral health services, they can only delegate to an individual who is in fact licensed under, it meets the licensure requirements in state law to deliver that service. So that is to be determined by the physician or a non-physician practitioner if that is in fact part of the provision of general supervision to determine that individual is appropriately qualified to deliver that service. Also, CMS reminds you that there is more to incident to billing than simply the supervision requirement, that in fact the services may only be billed, incident to services may only be billed if they are services that are provided consistent with an established course of treatment, generally referred to as the established patient diagnosed condition rule. And those still apply here. Interestingly, I noted that CMS made this clarification about billing incident to for services related to diagnosis, even though the traditional incident to rules require that it be services related to an established recognized condition. So there is some ambiguity there we'll have to figure out in terms of that auxiliary personnel being involved in actual diagnosis of an individual or determination of an individual's mental health condition. But this should be a significant advance forward, expanding out the availability of these services with that no longer requiring direct supervision, meaning in effect that these individuals from their own location can deliver these services and not have that physical attachment to the billing practitioner. The other change in behavioral health services made in the final rule related to general behavioral health integration. CMS created this reimbursement for general BHI back in 2018, 2019. The dates sometimes all mixed together for me. That reimbursement exists under CPT 99484, which is reimbursement for 20 minutes or more per month for the assessment and management of an individual's behavioral health condition. So it is a specialized form of chronic care management that is targeted towards behavioral health conditions. It is performed under general supervision of the billing practitioner. Unlike CCM and the other care management codes, there is no add-on code here. So it's 20 minutes or more. There's not an additional code available if you provide more than 20 minutes of general BHI. What CMS decided to do in this final rule is to create a new code, which is G0323, that is, instead of being billed by physicians and non-physician practitioners, this code can be billed by clinical psychologists or clinical social workers for providing these types of services. CMS did qualify that in order to bill for these services, that clinical psychologist or clinical social worker must first perform an initiating visit that meets the requirements of CPT 90791, which is the integrated biopsychosocial, there's a fine word, assessment. And so once you perform the 90791 going forward, there's this opportunity to bill for general BHI. And again, this is not necessarily the clinical psychologist or the clinical social worker personally performing the services. Then that can be performed by clinical staff under the general supervision of that billing social worker or psychologist. And note that this code, even though billed by a different type of practitioner, is going to have the same level of reimbursement as does the code for general BHI billed by physicians and non-physician practitioners. That weighs in at $41.99. Note, of course, clinical social workers are only reimbursed at 75% of fee schedule for the services they bill under their own MPI, so that will be a reduced rate if these services are furnished or supervised by a clinical social worker. Again, more of this CMS strategy of trying to increase access within primary care practices to behavioral health services for their beneficiaries. Next up, chronic pain management. New benefit created this year in the fee schedule. Chronic pain management is a monthly bundle of services that are focused on chronic pain management and treatment services. And you see here on the screen the different types of services that CMS would include within the bundle. Doesn't mean you have to provide these services every month. It's just that in the course of treatment, it would include all of these services for an individual. And CMS notes that these services generally, some are provided not face-to-face because the patient isn't directly involved. So if you are developing the treatment plan for an individual with chronic pain management, that time could be recorded as part of chronic pain management, even though you're not working face-to-face with the patient. But CMS notes that those services that would be typically in person, face-to-face, can be delivered via telehealth if you meet the applicable requirements. Remember, we said that there were those few new Category 1 telehealth codes that includes these codes for chronic pain management. So these services, again, you have to meet all the requirements, geographic, location, and the like, but you can deliver a portion of these services via telehealth. To bill for chronic pain management, the individual has to have a chronic pain diagnosis, which CMS defines in the final rule as persistent or recurrent pain that has lasted longer than 3 months. Doesn't mean that the person's being treated for that pain for at least 3 months prior to the initiation of services, just that the practitioner who initiates chronic pain management has determined that that individual has suffered from persistent or recurrent pain for longer than 3 months. There must be an initial face-to-face visit that is at least 30 minutes in length to discuss and develop chronic pain services, that chronic pain management services, generally separately billable service. And then the patient, of course, must provide consent to these services, as CMS always requires for any of these type care management services. The reimbursement for these services, there are 2 codes. The first is the initial 30 minutes, which reimburses at $79. Again, must be personally performed by the billing practitioner. So these cannot be provided incident to under supervision. These are services that are actually provided by the billing practitioner, and you have to click the full 30 minutes. It's not half the time, 16 minutes, the full 30 minutes to bill for this code. And then thereafter, for each 15-minute increment, it's about 28 cents. That's right at $29 for each 15-minute increment. And that's an unlimited number of increments. There is no National Correct Coding Initiative limitation, no regulatory limitation that CMS has put onto it. It is said, in fact, you can have unlimited units of G3003 that can be provided to the individual. So new benefit for chronic pain management doesn't quite fit into with our other care management codes because it in fact does require that the service is personally performed by the billing practitioner. This is not furnished by auxiliary staff. And it is truly a recognition of those practitioners that work with these patients, the significant amount of time that is devoted to helping these patients manage their conditions and providing this new kind of reimbursement beyond just the traditional evaluation and management services. Next up in our walk through the fee schedule are the changes for remote therapeutic monitoring. If you remember, CMS added reimbursement for remote therapeutic monitoring last year and distinguished RTM from remote physiologic monitoring in terms of the conditions being monitored and the manner in which data is transmitted from the devices performing the monitoring. For RTM, CMS in the final rule decided to maintain the current treatment management codes. So these are for remote therapeutic monitoring, for remote physiologic monitoring, there are three types of codes. There's the code that applies to the initiation of services and patient education, which is a one-time billed code. There is then the monthly code that you bill for monthly monitoring. And then there are the treatment management codes, which relate to the interaction with clinical staff to assist the patient, communicate with the patient, again, very similar to chronic care management services. CMS created a treatment management code for RTM. They kept those codes, and they determined that these services now can be furnished under general supervision. So last year when we created the RTM codes, we still required direct supervision for the delivery of treatment management services. So CMS determined instead that it will change that now. It will add RTM treatment management services to the list of recognized care management codes for which general supervision is permitted. CMS determined this was the better solution than what it had proposed in July, which was in fact going from 2 codes to 4 codes and having 2 of those codes that could be billed by physical therapists, occupational therapists, and speech language pathologists, rather than having that separate code for those types of providers. CMS said, no, we'll just keep the codes we have and we'll allow services that are furnished by PT, OT, and speech language pathologists to be billed under by a physician, provided there's appropriate general supervision in place. Also of note with regard to RTM in the final rule are some clarification of billing rules, noting that you can only bill treatment management services for a patient if you have in fact previously or in the same month billed for the initial patient education code and the monthly monitoring code. So you can't do RTM standing on its own. You also know this, of course, also CMS clarified that you cannot bill RTM in the same month in which you are billing remote physiologic monitoring, as well as cardiac device evaluations or blood pressure self-monitoring. So those are excluded codes from when you bill RTM. We always ask and we always look each year at the rule and hoping to see what else CMS, oh, I apologize. Not before we go to that. The other change they made to remote therapeutic monitoring is the addition of cognitive behavioral therapy monitoring. Presently, remote therapeutic monitoring is limited to certain conditions. There's a code that allows for reimbursement for respiratory system, monitoring of the respiratory system, and monitoring of the musculoskeletal system. CMS is adding another area to RTM, which is cognitive behavioral therapy. So we'll reimburse for those RTM services, but because the technology is still evolving, CMS is deferring to contractor priced services. So that monthly monitoring associated with RTM for cognitive behavioral therapy will still have to be determined at the MAC level. CMS is not putting a formal reimbursement in place at this point in time. Hopefully we see that roll around next time. Okay, I'll apologize for that. Finally, back to other virtual services. You can scour this final rule. There are no proposals that relate to current reimbursement for transitional care management, chronic care management, or remote physiologic monitoring. We always hope that they provide additional clarification on these rules. They are not. What is of concern is that these rules that CMS clarified on remote therapeutic monitoring, do they also apply to remote physiologic monitoring? Back last year, CMS said that it would incorporate the RPM rules into RTM. Question is the opposite true as well? Do we incorporate the RTM clarifications into RPM? Specifically, can you not bill treatment management services unless you're also billing for monthly monitoring? So requiring the 16 days of data and submitting the claim. The other issue of note in the RPM space is found in the 2023 Addendum B. Addendum B is one of those additional 27 documents that CMS posts with the physician fee schedule. It is the listing by CPT, by HCPCS code, of the assigned RVUs for every single service. So you see the work value, practice expense value, malpractice expense value for every single code. It's a really, really large Excel data sheet. This year, when you check the RVUs assigned to that monthly monitoring fee for remote physiologic monitoring, you see an 8% reduction in the RVUs. This is always the worry in the Addendum B because CMS will make changes to the RVUs that are only reflected in Addendum B and are not discussed in the formal final rule. This is one of those examples. So you'll see an 8% reduction in payment to those monthly monitoring fees as a result of that change in the practice expense, in the RVUs for monthly monitoring. Just of note, RPM is up for reevaluation by the AMA in terms of its practice expense assignments, so maybe we will see changes again next year that'll increase reimbursement for these services. Number next, very briefly, changes for colorectal screening. CMS has expanded coverage, first by reducing the minimum age and payment coverage requirements from 50 to 45 years. So you young folk can join us in the wonderful world that is colonoscopies at an earlier age, and that's consistent with the U.S. Preventative Services Task Force recommendations. You're saying, well, wait, Medicare is for people age 65 and older, so why do we care? Medicare also covers individuals with disabilities, and so this additional coverage is now available to that class of beneficiaries. CMS also expanded the definition of colorectal cancer screening to include follow-on colonoscopies after a positive result on a stool-based screening test. Previously, CMS treated that follow-on colonoscopy as diagnostic and not screening, which means the beneficiary would be responsible for co-payments and deductibles. Remember, screening tests are covered first dollar, diagnostic tests are covered after the copay, or that 20% reduction. That due definition, again, should mean that individuals will not incur that additional expense for colonoscopies. Next up is, once the screen decides to move, rural health clinics and fairly qualified health centers. Although they are not technically reimbursed on the Medicare physician fee schedule because they receive AIR and other PPS rates, CMS uses the fee schedule as the vehicle to announce changes to RHCs and FQHCs. You'll see here on the screen those changes. They impact the rate for telehealth reimbursement for RHCs and FQHCs. It includes the changes to the 2023 payment limit for RHCs, increasing it up to $126 error rate, consistent with the Consolidated Appropriations Act. And you see the changes made to care management services to reflect the changes to chronic pain management. Note, still yet again, CMS refuses to include coverage for RHCs and FQHCs for remote physiologic or therapeutic monitoring. Last but not least, and I'm going to just simply introduce this topic, are the changes made to the Medicare Shared Savings Program. It is its own deep dive. The answer here is it's almost all good news. CMS made a number of modifications to the program consistent with its intention of having, by 2030, all Medicare payments going through some sort of accountable care model, and appreciating that MSSP has been its most significant tool to accomplish that. The changes include delay in the mandatory transition to two-sided risk. So ACOs that have been on upside only can continue their status in upside only. A number of changes made to improve benchmarks, specifically to account for participation in shared savings programs, the impact that has on future benchmarks. CMS added a health equity adjustment to benchmarks and to quality scores, again, consistent with that broader CMS strategy to promote health equity within its policies. CMS is creating new advanced savings payments for new entrants into the program that meet the qualifications as low revenue ACOs. They're going to receive an upfront payment of $250,000 to help them build infrastructure, followed by eight quarterly payments. All that's deducted from future savings, but certainly provides that growth infrastructure for new ACOs. CMS is updating the quality metric scoring. In fact, it's one of those back to the future cases where they've eliminated the rules they had changed to go back to the old way of doing them. And finally, just a number of provisions that are intended to reduce administrative burden. You have in the handouts section of your screen the PDF of this presentation. It includes several more slides that explain these MSSP changes if you're interested in them. Again, as Laura noted at the beginning, we send a copy of slides as well as a recording of this presentation to you via email, and you can take a deeper dive in there. If you have specific questions regarding the MSSP changes, have any questions regarding any of the content here, please enter those in the chat feature, or you have my email address, shoot me an email on these questions. Apologize we weren't able to get to all of them, but discussing the conversion factor just takes too darn long and eats up more of our hours than I had anticipated. But thank you for joining us. This is my last HCRR webinar for the year, so happy holidays, everyone. Thanks for joining us, and we'll see you in 2023.
Thanks to our presenter, Martie Ross. If you have any questions, her presentation and contact information will be emailed to you, along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise, or to subscribe to receive PYA insights. Please remember to stay on the line once the webinar disconnects to complete a short survey. On behalf of PYA, thank you for joining us and have a great rest of your day.